published in HPB. So just quickly, this is no news to you how we break patients down in the Barcelona treatment algorithm. And you can see down there in most high-income countries how they envisage the proportion of patients that are treated in each of the categories. So between 30 and 40% treated with curative intent. TACE or TARE, the transarterial therapies, there's a target of about 20%. Sorafenib or the newer drugs that probably up to 40% of patients will benefit from, and then the SADS case of the stage D patients that only undergo best supportive care, and that proportion in high income countries is about 10%. This is what you can expect for treatment, sort of a ballpark figure. Patients that are treated with liver resection, especially inside the Milan criteria, very good 5-year survival. Local ablation similar. Sorry, liver resection was first, transplantation here, more than 75%. TACE and TARE maybe even a little bit better, gives you a 20 to 24 month improved survival if done with the conservative indications. We are expanding indications due to the fact that we don't have access to any of the systemic therapies. The problem that we see now, and this is a slide I've shown before, I think in the first meeting when we start these HCC sessions, you can see there the BCLC stage of presentation. Study from Europe that showed 40%, and that's more or less in line with the Barcelona criteria expectations, and that means that 40% of them will be treated with curative intent. In sub-Saharan Africa, we had 5%. We go to stage D, 14% in Europe, patients that are treated with best supportive care. For us, it is much, much higher. We're very close to 99%. So this, I think, was up to date, or until recently, the best evidence we had on how patients were treated. But we do have much better data now, also with outcome data that we're going to look at. But first of all, Rashid, you can start and just give us your presentation. Just going to unshare.
Thank you, Prof. Yes. So we'll just share our experience with treatment of HCC in Namibia ever since we came back to Namibia after we finished our training in Cape Town. So I think most of the statistics, we probably all are aware that most of our patients present with advanced disease or even terminal disease. And most of the newly diagnosed HCCs found in Southern Africa. So as I said, we just share with everybody the experience of treating HCC and the treatment options that are available in Namibia. And we'll demonstrate with a case that we recently done with some of the colleagues here. And then we conclude. This is our capital city. I live in Windhoek. It's a national referral center at the Windhoek Central Hospital. It's the only country where, the center, we have hepatobiliary services for the whole country. And just a bit on our statistics, we also have a problem of data capture. And most of these patients are actually, all this stats on cancer is taken from the pathology specimens which are admitted to the laboratory. So by and large, patients who have only diagnosis based on the CT scan will obviously be missed in this registry. So quickly, just to explain what are the treatment options, Prof has already shared this slide. This is one of the updated slides with more treatment options. For the early cancers, the mainstay or treatment or curative intended treatment is a resection. I put a question mark on ablation, because we haven't really started ablation, but we've sort of started to speaking to the industry if they can bring ablation services into the country. Obviously, transplant is not an option for us, but we can refer to the to South Africa at the Donald Gordon Center for Living-Related Transplantation, if possible. We haven't done that yet. And then, of course, the TACE is available. We'll experience, I'll share my experience with working with a vascular surgeon. There's no interventional radiologist who can actually do the TACE at the moment. And obviously, we do have systemic therapy that is available in the country, like sorafenib and the rest can be motivated for. In terms of our experience so far, from when we came back from 2019 to 2023, we've done about 33 liver resections, of which 8 hepatocellular carcinoma. So a majority of our limited liver resection actually from gallbladder CA. But with colorectal cancer, liver metastasis, and hepatocellular carcinoma, it's almost like a quarter there. So the case that I'm sharing with you is a male patient who is 57 years old. He initially presented in the north, which is about 800 kilometers from Windhoek, with in a place called Oshakati. He presented there with a right upper quadrant pain, and he didn't have any jaundice symptoms and no weight loss. And an ultrasound was done that picked up multiple lesions within his liver. And then immediately went on to have a CT scan at the referring hospital. The referring centers do have access to a CT, and then he was then sent to us for further management. Just in the past medical history, he is known with a chronic hepatitis B infection since June 2021. He's virally suppressed on tenofovir and lamivudine. He doesn't give any history of alcohol consumption. And the other than the current medication, he's not on any other medications. So on physical examination, nothing really of note. He was a good performance score candidate. When we examined the abdomen, he didn't have any features really of chronic liver disease per se. And then furthermore, his liver functions, his bilirubin was 10, very well preserved liver functions with the albumin of 45. The ALT and the AST, in keeping with a good treatment, is not elevated. However, his alpha-fetoprotein was over 4,000, and the blood count did not really demonstrate features of portal hypertension either. We scored him with a child Pu of 5 points in class A. And then just a part of completement of these workup, we did an ultrasound and the CT scan, which we'll share shortly. Yeah, so it's not routine for us to do biopsies of these patients, but because we were involved in the hepatocellular carcinoma with Dr. Sobnach, the patient was biopsied, and it was actually done by my medical officers in the ward, usually for interventional things like liver abscesses and large tumors of the liver. We've actually taught them how to do some of these simple procedures. And this is a CT scan that was done at the referring hospital. On my left is the arterial face. I'm just going to go through quickly. You can see that there's a lesion in the posterior segment on the right side, and another one in segment 2-3 there. And no really features of ascites or cirrhotic looking liver. It looks more smooth on this arterial face. And there's just a little bit of enhancement on the arterial face. We sometimes have poor quality imaging that is done for patients that had CT scan done outside of Windhoek. And then on the venous face, let me just stop this one. We can see the lesion there coming through in the posterior section of the right side, very close proximity to the IVC. And then you can see compared to the other face, the arterial face is more hypodense, which somehow demonstrates a washout phase of the HCC. So this patient was then discussed at our MDT, and we thought this patient sort of falls within the intermediate Barcelona stage, and the decision was from the MDT was to offer him transarterial chemoembolization. Obviously, not to go further much into the rationale, that the HCC obviously gets his blood supply from the arterial system, and then the idea is to actually put the chemotherapy agent through the artery system directly into the liver, and then also maybe embolize to reduce the blood supply. And we need just to differentiate between just blunt transarterial embolization just with the chemotherapy agent, and where you don't offer embolization. And obviously, there's studies comparing convaltase versus drug-eluting B, and also trim. So this is our experience with the TACE so far in Namibia. We have been doing it since 2019 with a vascular surgeon, because he's more familiar with embolization and endovascular procedures. So far, we've done 10 patients now since 2019. We started with doxorubicin, and then we followed up with coil embolization. But since probably the last 6 patients or so, we have been doing with microbeads, with drug-eluting beads. Okay, and the advantage we found with that is that you can actually repeat the TACE without not blocking the blood supply completely. And most of our tumors are less than, or at least 10 centimeters. One patient obviously had an extension into the IVC, and 2 of the patient had repeated TACE, although it wasn't really a good response, and one of them demised. And then we usually ask the radiologist to repeat the scans 90 days after the TACE, so that we can actually reevaluate whether we should continue or maybe give best supportive treatment. This is just the setup in the fluoroscopy room. Initially, it's one of the local hospitals at Boamba Hospital. Usually we use the theater, usually the same theater with the cardiologist and as well the neurosurgery team. But now it's available to for ERCPs and as well vascular surgery since the cardiacs moved out. So this is, I don't have the fluoroscopy imaging or the imaging, but this is the same patient. The procedure, we've done it on the 21st of September. And then you can see the catheter and the aorta. We went via the brachial, and then he was able to super select the tumor in the right posterior. And then we ingested doxorubicin beads. And then the patient spent 1 day in the hospital or so. Okay. So basically, yes, we do have problems with the data collection. We do have liver available, resection available. Our bed is most for the state, for the private patients. For the majority of our state patient or public patients actually present very late, not really meeting the criteria for a resection, and they're either cirrhotic and without much support from hepatologists and things. We just a bit too scared to try patients with advanced liver disease, take them to surgery. So far, we haven't had any mortality related to the procedure, but rather disease progression. So it's very good to really select the patients well. TACE, we demonstrated it can actually be offered with the use of other colleagues with expertise, like a vascular surgeon. Yeah. We are very happy that we're actually involved with research with the Cape Town team. And it was just in short our experience and the case that we managed recently. Thank you for the opportunity.
Okay, thank you very much, Rashid, for a very nice presentation. I think it does discover some of the typical finding problems that we face. Just a few comments. You mentioned that you think you underestimate the incidence of HCC, and that's a problem I think that we've got everywhere. we've got the same thing in South Africa, that the cancer data is based on the number of patients that have had biopsies, and we know that's the minority. So I think in South Africa it's regarded as the 26th or the 20th most common cancer. That is clearly a grotesque underestimation. Just a ballpark figure of all the patients that you see with HCC, what percentage do you think would be candidates for a resection?
Prof, by just looking at our data, I mean, there's always a patient in our ward with the HCC and other surgical wards. I think it's probably less than 5%, Prof. It's not really a lot at all. And those ones that we resected are those ones with normal livers, really. Yeah, it's probably less than 5% for the resection. Those who end up with the resection. Very small number, Prof.
Are there any other questions or comments for Rashid? You can put them in the chat as well. I'll keep an eye on that. Rashid, just tell me, so is TACE now permanently established in your service as a treatment option for patients?
Yes, Prof. It's actually for the state patient, we have to really motivate for them because it's done at the private hospital. And the state has to approve because they obviously have to do the payments and all that. But for all our private patients, they actually it is available. Yeah, but yeah, in short, yeah, it is actually established part of our protocol now, and yeah, it is freely available, easily available for patients. Yeah, who qualify.
Okay. I see we have one question in the chat, but let's go to Karan Gandhi in Kenya first. Hi, Karan.
Hi, Prof. Hi, Rashid. Thanks
Hi,
for the
Karan.
talk. Just a question regarding your practice or what you think about this, because what I often face is that patients, I don't think I've seen a single patient in Barcelona A or 0. So what often happens is there is a gathering body of evidence that we can resect if you have a solitary large HCC, which is above the 5 centimeter mark, even, that there's evidence to show that there's still a survival benefit. So do you think within the realms, I mean, within the confines of MDT, would you push to do resections for patients outside Barcelona? So an intermediate stage, maybe with a 6, 7, 8 centimeter tumor, would you push to resect if the patient has a good Child-Pugh score, normal underlying or compensated underlying liver disease?
Yeah, I mean, absolutely. I mean, that's what most, if a patient is young and the normal looking liver, not cirrhotic, I think the greatest size that we've done is probably 12 or more. Yeah, so we've actually done bigger size tumors. Some, of course, you have to choose the patient very well. It's maybe like a pedunculated big tumor that is easy to resect. But yeah, I wouldn't do, for example, an extended right or left kind of procedure. But majority of our patients, the tumors are more than 5 centimeters. And yeah, the biggest one we've done is probably, yeah, like 12 with a right hepatectomy. But on this specific patient, we had to do sort of ligation, portal vein ligation. Yeah, because we had to biopsy the contralateral side. He was a bit fibrotic, grade 1, I think. So we had to do a portal vein ligation because we knew we were going to do a right hepatectomy. But yeah, we have pushed a bit of boundaries but we have to just be careful not to end up with post-hepatectomy liver failure and all those things that you can't really rescue the patient. Yeah, we have done bigger tumors, yeah.
Thanks so much, Rashid. There's a question here. Did you repeat CT and AFP post-TACE and what the response was? That's from Zambele.
Yeah. So the pre-test AFP we showed is more than 4,000. We've only done the patient about 3 weeks ago. is coming back in 90 days. So before they repeat CT, we always do the alpha-fetoprotein again, do the liver functions again, and then we image, and then we decide further. Yeah, but in the previous patients, the taste, usually we have demonstrated that it does go down. I didn't show that case. It was already presented some time back. But yeah, yeah, we do. It's part of the workup to repeat the AFPs and yeah, to assess whether we can still do the taste if the patient is still tasteable. But if there's severe progression, we refer them to oncologists for palliative chemotherapy. Yeah.
But this patient, I'll come to Stanley Thompson now. This patient, the planning forward would be if you get the alpha-fetoprotein down and the patient maintains a good performance status, that you eventually will operate.
Yeah, so if you look at the CT scan, Prof, it's mostly on the right posterior segment, right? And there's a small lesion in segment 2. So initially I thought we can probably just cut it out, but then we will also reassess and then bring him to the MDT again, and then maybe perhaps share the images with you to see whether can we offer him a resection and a wedge on the left side if the tumor has shrunk considerably. Yeah, so we will reevaluate again in 90 days, Prof, to see what we can offer him.
But we would have done the same. We're very hesitant to resect with the alpha-fetoprotein that high.
Yeah.
Sandy.
Sorry, can I ask, just in respect to what percentage of your population is covered by medical insurance, and to what extent you think they're a different profile of liver disease? And just generally to give us an overview of what percentage have medical insurance.
Yeah. So a larger proportion, Prof, they have, thanks for the question. A large proportion of patients actually have the public medical aid, which is called CMS. So that is probably, all in all, I have to check the figures from the medical aid. I think it's about maybe 20% of the population, Prof, probably covered by the medical aid. Yeah, I think it's about maybe in the region of 20%. What was the second question, Prof? I'm sorry.
I think that's the essence of it. So there is a significant population, because even in South Africa, our percentage insured is much less than that. It's of the order of, it's under 15%, probably nearer 12. And in most other African countries that I know of, it's under 5%. So the other thing, obviously, you've managed to get a public-private partnership going to some extent for patients for TACE. And again, maybe, I don't know how, obviously it's on a case-by-case basis, but do you think that's a way forward to try and expand what you can do for your other patients?
Yeah, certainly, Prof. So the superintendent's office will not, for example, even consider an application without having gone through the MDT, for example, for a state patient. So all the patients, we have to give reports and the MDT, and then give it to the superintendents. Usually there's a committee that actually approves the application for treatment that can be done in the private. And it includes a lot of things like dialysis, other vascular surgery cases. So it's on case-by-case basis, and writing a motivation to the management, and then they approve. But once it's approved, everything actually just goes well. Yeah. So it's actually more accessible for most of our patients, provided we give good, strong support or motivation for them for the treatment.
Thank you. Thanks very much.
Thank you.
Okay, thank you very much, Rashid. I think we can move on to Sanju. So Sanju, if you can share your presentation and start.
Yes, Prof. So Thanks again for welcoming me on this platform. My talk is essentially one of our recent publications we've just put through to HPB. It's a systematic review regarding the management of outcomes of HCC in sub-Saharan Africa. We've essentially gone back to every single publication from 1940 to June 2023. I'll just take you through some of the data here. So, as we know, HCC is the sixth most common malignancy worldwide. It accounted for about 5% of all new diagnoses in cancer diagnosis in 2020. 80% of all HCC diagnoses come from sub-Saharan Africa and Southeast Asia. Certainly in our setup, HCC is a huge problem. It's the second and third leading cancer in men and women respectively, and that's in the whole block. In 2020, there were about 38,000 new HCC cases diagnosed, and about 36,000 deaths during that period. The standardized incidence of the disease is as high as 102 per 100,000 in some parts of the country, and that data really is from Mozambique, where a very large number of these cases are seen every year. There's some cardinal differences between HCC in the high-income world versus low-income countries. In high-income nations, HCC is predominantly cirrhotic. The median age is 65. MAFLD is on the rise, and most centers will aim for survival rates of 70% and above when they look after their patients. In sub-Saharan Africa, it's a bit different. Based on prior data with respect to this current systematic review, about 40 to 80% of patients were deemed to have non-cirrhotic HCC, about 40% were hepatitis B related. And the responses to therapy were generally poor, quite heterogeneous across the various papers. And the median survival, interestingly, with a drug that's used until recently used quite prolifically overseas, sorafenib, is only about 106 days. And that's from Ethiopian data. So we embarked on this task of looking for data to produce this systematic review. I must be very honest with you, a lot of these papers were not available online. So although the citation was available online, we actually had to go dig through very old libraries to get paper copies. So, through this, I want to thank Karan and Rashid and Onisai for going through very old papers and getting us this data. And we even got one or two of the papers from one of the very old archives up at Oxford. So we started with 7,488 records. We cleaned the data and went down to 1,920. We screened those papers and identified 17 publications that were suitable to be included in this review. We then went through the references of these papers and identified a further 22 publications. We managed to get all these papers out, so we had 39 papers which were included in the systematic review. We were lucky enough not to place any language restrictions on this because we collectively spoke pretty much everything that was out there. So just to show you, table is a bit tedious, but I'm just showing here how we appraised the data. We used the traditional Newcastle Ottawa score, and we appraised every single publication that was out there. There are two arrows on the right-hand side. For me, that was very interesting. For a disease that has such a massive impact in Africa, there were only 2 randomized controlled trials ever performed in Africa for HCC. And both of them actually come from the University of Cape Town. Berman looked at various oncological therapies for HCC treatment, particularly those with pulmonary metastases. And the trial was the use of Natalan versus best supportive care, and that showed that there was no difference. And the other trial was the landmark study published by Madden and al. In Gut in 1993. As you can see, both these papers scored 8, so that's the highest score you can get on the appraisal scoring system, and that was mainly because these were 2 randomized controlled trials. The rest of the papers really scored a 5 or a 4. But I really wanted to say that, you know, the papers that were written in French were of excellent quality. They generally had about 300 to 400 patients, but clearly the authors had language limitations and essentially published this in their local journals. I'm not going to go through this in detail, just to say for those of you who are interested, we've summarized every single paper, and that includes the publication, the study period, the number of patients, the age range or the mean or median, whatever was available from the data, what treatment was performed, and what outcome was available. I mean, if you look at the top of this table, this was a paper from Nigeria that had 89 patients that offered best supportive care to 100% of these patients. And the mean survival reported in this paper as the primary outcome was 6 months, and the range was 3 weeks to 2 years. And that applies to every single publication that was put in. This map is, I think the journal was quite pleased with this. It essentially shows you where all the data comes from. So this is sub-Saharan Africa. Every star represents a publication. If your country is in blue, it means you have a published study. Yellow countries do not have a published study. And you can see that the majority of papers, actually close to 60% of these papers, came from Nigeria, Ethiopia, South Africa, Sudan, Togo, and Uganda. And most other countries either had 2 or a single paper looking at HCC treatment and respective outcomes. So what we had was 3,989 patients included in the systematic review. 74% were male. The mean age reported was 32 to 62. Whenever hepatitis B testing was done, the peak positivity rate reported was 80%. In 26 studies, 5 to 80% of the patients were reported to have non-cirrhotic livers. And the incidence of portal vein tumor thrombosis was 41%, and that's quite alarming. In terms of extrahepatic disease, 2 to 59% of the patients had extrahepatic mets reported, and pulmonary metastases were the most frequently seen or reported. 21 papers. Best supportive care was the only treatment offered to 90% of the patients. In 20 publications, a single modality of care was offered that could be only best supportive care, or only liver resections, or only hepatic artery ligation. There was not a single publication out there that reported on all available treatment modalities. So by that, I mean there wasn't a paper that reported on best supportive care, resection, ablation, transplantation, TACE, and put all of the levels of care into context. That was absent in the literature. 12 studies reporting on 1,142 patients, so close to a third of the cohort, was data from 1990, which makes you really think that this data must be purely historical, probably except for those who were treated with best supportive care. And this is the end result of it. When we synthesize the data of those 3,989 patients, 6% have curative care. Of those, 174 patients had resection, so that's 4% of the total study group. 1% were ablated, 1% got liver transplantation, data reported only by the Donald Gordon Medical Center in Johannesburg. 8% got transarterial interventions and oncologic therapies, and the great majority, 84%, were only offered best supportive care. So just some outcomes. I'm just going to list some of the most salient ones out there. For liver resection, 1, 3, and 5 year survival rates of 85, 75, and 62%. This is Cape Town data, a study by Prof Cricker that looked at liver resections in 14 patients. Then a follow-up study of the same sample of patients, including new recruited patients, a cohort of 18 patients, 1, 3, 5 year survival rates of 100, 56, and 38%. Just to look some Sudanese data, 30-day mortality of 9% for major liver resections with no long-term survivors. And Togolese data only reported perioperative mortality of 25%. In terms of ablation, if you look at some of the Senegalese data out there, we're the only ones who've ever reported on this. Only 1% to 2% of the patients get ablated. 1% had radiofrequency ablation and percutaneous alcohol injection in 2%, but no perioperative mortality reported. In terms of the Sudanese data, they were quite interesting papers where they performed hepatic artery ligation, but supplemented that therapy with percutaneous alcohol injection. Those were for large HCCs. I think it was a series of 10 patients, a median survival of 14 months. And the transplantation data is well comparable to what we have overseas, 1 year 5-year survival data, 77 and 61%. This is quite an interesting paper to read because most of these patients were transplanted, were well out of criteria. I think those patients would have certainly not been offered a liver overseas. In terms of TACE data, a single paper from Ethiopia where they combined TACE along with sorafenib offered a median survival of 353 patients. It was for a series of 8 patients. Sorafenib only data is from Ethiopia in the form of quite a short correspondence paper, median survival 106 days. And if you look at best supportive data, the in-hospital mortalities is 3 to 58%, and long-term follow-up less than about 1 to 2% alive at 1 year, which is very menial. For us, the discussion points here really is that HCC is a malignancy. It's got the highest fatality ratio when it comes to cancer in sub-Saharan Africa. It's quite shocking that for a population of 1.2 billion and an HCC peak incidence of 15 per 100,000, we only have 39 outcomes papers. 1/3 of those are purely historical and were published before 1990. What we certainly learned from this paper is that HCC in African patients is quite different. Unfortunately, our people here are generally young when they get this disease. They have large tumors, very often non-cirrhotic livers. A significant number have portal vein tumor thrombosis, and extrahepatic metastases is something that we probably see on a weekly basis here at our institution. There are really no national registries out and out in this part of the world. Well-kept institutional registries are very, very rare, with long-term follow-up that's probably not heard of. Screening of pregnant women and PMTCD programs will probably be a vital step in controlling this disease in the future. We don't have enough data for our stakeholders, and it's often a vicious circle. So we can't really apply for grants because, first of all, we can't actually show that the disease is significant and the outcomes are bad. So to earn credibility out in the scientific world even becomes a bit more challenging. And there are no specialized care centers for HCC in our part. I'm proud to say that at our institution and now Rashid's and soon on his side, and I hope Karan will join us very soon, every single HCC patient that walks across the door, compared to a number of our North American programs, gets care for free, irrespective of whether they're South African or not. And I'm very happy to say that 99% of our patients are enrolled in a study. So every patient that's been coming to see us from the middle of last year to now is enrolled in some form of HCC study at our institution. And that's how we treat our patients. They're involved in quite a high-end science. And I just went through our data yesterday just to look at our 624 patients we currently have with more than 90% long-term follow-up. And I'm quite surprised to see that it actually echoes the data that's in the systematic review. 72% are male. We have a bit of a higher resection rate of 13%. 3% were ablated. We are aggressive tasters. We taste close to 1/5 of our patients. We would do 2 to 3 tastes a week. We've transplanted only 1%, and the majority of our patients, 63%, get best supportive care. Our median survival in our cohort of 624 patients is 68 days, and the range is from 0. We've had patients who die on the day of the admission to 5,741 days, and I'm quite happy to say that was a patient that had a right hepatectomy close to 20 years ago, who's currently still well and lives in the UK. And this is what we are currently doing. We've recruited 150 patients now for our study, and Rashid has now provided us with 10 more, and I look forward to our people joining us soon. We have started interrogating the entity of non-cirrhotic HCC quite aggressively. This is our preliminary metabolomic data that shows that these are completely different tumors. The from a metabolic point of view, they're extremely aggressive. They produce large amounts of GLIC-B and GLIC-A with a high phospholipid profile. We know also that if you match the patients to the cirrhotic ones, they don't seem to perform that well. We've also identified markers that predict outcome in our population. High levels of beta-hydroxybutyrate as well as high levels of creatine seem to influence the outcomes, and the p-values are pretty much zero here. We also know that HIV in our cohort is a major killer, and lung metastases patients, contrary to what we believed, do poorly. We are also integrating metabolomic data into our radiology, so I'm hopeful by the end of next year we should be able to take a picture of a scan, and that will predict the metabolomic profile of the tumor without actually having to do the metabolomics on the blood. We've isolated exosomes, and now we're about to start single-cell RNA sequencing. We've procured the equipment, and we should be going over the next 6 weeks. I'm going to stop here just to remind people to do systematic reviews. They can be extremely tedious and painful to do, but in our setting, we felt that they are really the Achilles heel to performing high-end research eventually. Without them, you can't really prove that there is a problem and attract grants. I'm going to thank you for your attention. I'm quite open to any questions.
Thank you very much, Sanju. A fantastic talk. Are there any comments or questions for Sanju? You can just raise your hand, or you can put your questions in the chat group. Okay. Sanju, just in terms of the cooperation, I think that's something that we should talk about in this meeting at the
I think there's a question in the lot here. Is the patient with the 5,000 day survival Hep B positive? And I can tell you 100% no. She did not have hepatitis B. It was a very well differentiated large HCC, about 12 centimeters in diameter in the right lobe. She currently lives in the UK, is followed up with a NHS, has an alpha-fetoprotein once a year, along with an ultrasound of the liver. It was also interesting to note that she was a non-secretor. Her AFP never went up. She had a resection. She complicated with a seroma. She went back for a washout. Then she went back to her home in Durban and recovered over the next 3 months.
Yes, Dr. Ali.
Hi, Jonas and Sanju and all the speakers. Thank you for excellent presentations. I'm a physician, as you know, as a gastroenterologist, but I'm referring particularly to Karan Gandhi's question about operating beyond Barcelona criteria. And I know as surgeons, we instinctively would like to do this, but I like that you showed the data from Cape Town that if you obey the rules, you get good outcomes. And just because you think you can operate, you shouldn't be. Because as you've shown, that people who look healthy and are non-cirrhotic are actually doing worse than people that are cirrhotic now on the metabolomic studies. So we shouldn't get carried away. And I think, Jonas, I think in Tokyo, maybe you were part of that, people asked the question, catch a metro rail. Can you operate beyond the guidelines? And I think the answer should be no. If you stick to the guidelines, you'll get a better result. Instead of thinking, I can't do it because I am there, you shouldn't be doing because you're not doing any benefit. I'm sorry, I'm just making that point. Maybe both of you can comment.
Yeah, Prof. Ali, I'm going to make a comment about this. So if you look at this data for the metabolomic data, there is an inherent element of bias in there. And the element of bias is that, for example, in the number of patients that we've recruited so far, we've only done 2 hepatectomies so far. And one of them was the largest hepatectomy we've done for a 4.8 kilogram tumor. And the patient has done extremely well, was non-cirrhotic, and has gone home. So I think one has to be very careful about how we look at our biological data. Our biological data is on patients who've been recruited from last year, the majority of whom have extremely advanced disease. Yes, it might well be that the tumor itself is inherently more aggressive compared to the others, but it just potentially also means that the tumors need to be treated in a more aggressive fashion. The other thing I want to say is that, I mean, I certainly did my transplant training in an institution where Paul Gregg said, we must actually do everything that's illegal. I mean, he used to say that, you know, we breached every single guideline that there was. If you look at transplant criteria until lately, is that everybody was quite conservative, looking at Milan criteria or Barcelona criteria or some of the Japanese criteria. I mean, in Toronto, the rule was quite simple. Size didn't matter, number didn't matter, biology mattered. So we biopsied every single HCC patient who we deemed would be transplantable beyond criteria. And if their biology was good, and the surrogacy for that was moderate differentiated or well differentiated tumors, had no further cachectic symptoms at the time of transplantation, and
you have the survival figures.
The survival figures were equivalent. The 5-year survival in the Toronto criteria is 80%. I worked there for a good 3 years. It is very equivalent. So I think one must be very careful when we do that. We are certainly at a disadvantage. 50% of our tumors are non-secretors. We rely on criteria that rely heavily on AFP. So we can't really compare. I understand your point. I think there needs to be a lot of poise, and we need to apply our minds when we treat these patients. But I also think that we need to question biology. And, you know, if we question biology appropriately, we also have the opportunity to question the standard of care we're offering at the moment. Because if we keep on following the rules that have been set for patients that are not in our setting, I think we're looking at exaggerated results in a way.
Yeah. Thank you, Sanju. Excellent explanations there.
If I can just comment on that as well, you know, in Toronto, they went the other way, is that they extended indication, I think, in a very good way, looking at something that we should have done a long time ago, and that's looking at biology and not counting the size and the number of the tumors. But that should also go the other way, and that ties in with one of the questions that we had here. Do we, where was it now? Do you just make radiological diagnoses? It was from Sandy and Paul. Or do we look at histology? So for instance, this large resection that Sanju spoke about, that patient we did do a biopsy on, and we made sure that it is not a poorly differentiated tumor, and we would probably not have done that. And I think we have to even look at our current indications of resection. And you know, as much as we criticized biopsy, I think it's inevitable that it's coming back. I don't know if it's going to be replaced by imaging or functional imaging that is also sort of developing fast, and that will be able to tell you what the differentiation is. But there's probably patients nowadays that we operate within, or sort of with quite conservative criteria, where the biology would dictate that you should do otherwise and not operate the patient, because the outcomes are extremely poor. The patients probably have already metastasized, and a less dangerous therapy like a TACE would probably more be appropriate in some of those patients. So I completely agree with you, but I think the challenging of the guidelines should be up and down, because there are certainly things that we do within criteria that we shouldn't be doing if we really look at it critically. And just one more comment. If you look at the survival advantage that you get even with a doublet therapy at the moment, that costs a lot of money. We can't afford, and I don't think any of the medical aids in South Africa will pay it. That the survival advantage of that is still in general terms quite modest. If you stay within the accepted criteria for a TACE, you're looking at a survival advantage of somewhere between 20-25 months. Even if we can achieve 12 months with extended criteria in patients that we treat palliatively, we are still better than what can be achieved with most systemic therapies. So, and that Sanju mentioned, that we are very aggressive with TACE. And we have fortunately not, we've had few complications, but we haven't had a death. And that certainly can't be said for even our surgery patients. So I think we're in a time that we really have to apply our minds to how we treat patients. And in that way, it's actually quite exciting times. Yes, Sianda.
Thank you.
Hi, Prof. Thank you for a great talk. You've sort of answered my first question, which was to say, are we now going to move on to advocating for taking biopsies on patients? And I think the other benefit is now with targeted immune therapies, it's probably, it may make a difference for some patients if they have relevant immune markers. If we are taking biopsies, would we then take them transcutaneous or transjugular? And what about the risk of seeding along the tract?
So if I can just quickly answer that, I think the old dictum that you must ask if you're going to do any investigation on a patient, how is it going to influence your management? And if it doesn't, don't do it. And I think we have to still be a little bit selected when we're doing biopsies, but certainly in some cases, biopsies are going to become routine. There's probably a little bit of guidance necessary that should happen pretty soon on what is the place of biopsies in the more modern and the evolving management of HCC, and then the risk of the biopsies. There are obviously risks associated with it. I think the opponents of that, and I'm one of them, maybe exaggerated the risk of spreading, but going through a normal cuff of liver preferably probably protects a little bit against that. The transjugular biopsies, transjugular biopsies of livers can be done, but I'm not sure you're going to reach all tumors that you want to biopsy transjugular, and there may also be some cost repercussions for that. I hope that answers your question. Sanju, you want to add anything?
Yeah, there's one single system. We tried looking at this. So does biopsy increase your risk of seeding? I mean, HCC, there's one systematic review a number of years ago with the Birmingham group, and they set the value at about 1.3%. So it is low. It's very low. I mean, we have to say, what do we benefit, like Prof is saying, out of a biopsy? Certainly biology, immunology, if you have a transplant program, trying to list them out of criteria. And not to forget that, it's so important that we start questioning what we're doing, investigate what we're doing. There's an element of science to academic practice, and getting an extra core of tissue and storing it in a biobank can be very helpful for your patients in the future. So yes, if you're doing it, I mean, there are various aspects to it, and one to think about everything.
All right, I'm just trying to see if there are any more questions here. There was one, Sanju, that you maybe can ask. Is there a change from the 1940s to the 2020s with regard to the underlying risk factors, for instance, HBV or MAFLD?
Yeah, so HBV remains the main dish. I mean, we see that. I mean, if I don't see an HCC that's hepatitis B related, 90% of the time, I really question whether I've done adequate testing for the patient. We are seeing more and more MAFLD, and those patients surprisingly tend to do a bit better because they are referred from a screening program. They are either referred from Prof Sonderup or Prof Spearman's clinic. So we see those, but those are very few at the moment. I would say that's about 10% of our current cohort. Yeah.
All right. Thank you very much. If I don't know if there are any other comments or questions. Otherwise, I'm just going to conclude, and I just want to share my screen again. And let me just get it up there. Yeah, so this is just a reminder, and I think you all know about it, that the International Hepatopancreatability Association meeting will take place in Cape Town from the 15th to 18th of May 2024. This is not only a surgical meeting, there's a very big legacy initiative associated with it that we are going to, in which we're going to address HCC in sub-Saharan Africa, that, as we've just shown you, is a really massive problem. So this is going to be, apart from the usual IHBBA meetings, a central theme in the meeting, but more importantly, in a parallel program that will go parallel to this meeting. So the IHBB meeting runs about 5 or 6 parallel sessions. The legacy project with our partners will probably occupy another 3 to 5 sessions. So we at some days looking at 10 parallel sessions. So it's going to be a big meeting. The legacy initiative is not only surgery; it covers everything that potentially has got anything to do with HCC, from the etiology, the screening, the surveillance, and for that it's going to be a viral hepatitis convention organized by the Gastro Foundation and GASA. That Professor Chris Gazanidis, that's in this meeting, is the chair of the organizing committee. So I think every hepatologist and physician that deals with these patients will benefit from that. There will also be separate surgical sessions outside of the official IHBBA program that specifically will look at the challenges in the way that we treat currently in sub-Saharan Africa. And very important, there's going to be sessions, I think it's a full day session at this stage, from the African Palliative Care Association, a part of the treatment of these patients that has not been given the profile that they need, because on our continent, primarily, probably more than 90% of patients are treated palliatively from the start, and even patients treated with curative intent, many of them eventually will need the care of the palliative specialists. So just to say that for colleagues that would like to attend the IHBBA meeting, and by the way, one registration gives you the ticket to attend any of these meetings. There's a special rate for low and middle income countries that is quite low. I can't give you the exact number, but I think it's in the region of $200, $300, but we can come back with the exact figures later. And so not an expensive congress. Well, everything is expensive these days, and that's what brings me to possible grants. There will be some travel grants available for people that submit abstracts to these meetings. The official date for or closing date for abstract is actually today, but I'm not sure that in my experience there's usually a 2-week extension. So if there are some of you that have abstracts that you would like to submit, especially if you need help with abstracts that need to be submitted, or people to help you to put them together, it's not that easy the first time. You can please come back to us by email. I think Cheryl can just, or there's an email to Cheryl, I think, that you can use with any questions. She can forward it to us. And then finally, there's also going to be from the IHBB a new initiative where they're going to pair units and training institutions from high-income countries with middle and low-income countries. And there's the focus in this meeting is going to be pairing units from Europe and the United States with units in sub-Saharan African countries. And there will also be at least a half day, but I think possibly a full day session specifically on that. So just to highlight this meeting, and the invitation to all of you are there. If you need more information, you can contact, I think the best would be to contact Cheryl. She can forward to us, and we can take it from there. Cheryl, I don't know if there are any contacts from your side.
Contacts? Sorry, yeah, it.
Yeah, so just the contact details I'll
put my email in the chat.
If you just put your email in the chat, and people can just quickly look at it.
Yeah.
And while you do that, it just remains for me to thank everybody for their contribution. Thank you for everybody that attended and the questions that made it a very nice discussion. And I also particularly want to thank the Gastro Foundation, GASA, and also the iEcho initiative from Albuquerque, New Mexico, and specifically also the colleagues in India that usually help us with these meetings. And also to Cheryl and Karen Fenton for always making these meetings run really smooth. So I think we've had the there we go. We've got Shirley Valentine at uct.ac.za, and there's a second one, echoworks2020@gmail.com. So if you have any questions or you need any help, you just let us know. Thank you very much.
Thank you. Bye.
Thank you, Prof. Bye.
Thanks very much. Bye.